Welcome to the deep dive. Today, we're really zeroing in on the clinical side of things.
That's right. Specifically, the venous and lymphatic systems.
Yeah, in the arms and legs. We're working from a chapter in Rutherford's vascular surgery text.
And our mission really is to pull out the key ways doctors actually assess these circulatory networks.
Okay, so just quickly, veins, they bring blood back to the heart, one-way flow.
Right. And the lymphatics, they handle that interstitial fluid, carrying waste back.
And when that flow gets disrupted,
Yeah,
well, that's where the problems start.
exactly. That's the root of many of these conditions we'll discuss.
So we'll cover the anatomy first. Deep, superficial veins, lymphatics. Lower limbs, then upper.
Precisely. You need that map, that anatomical grounding, before you can evaluate clinically. Let's start with the lower extremities.
Sounds good. Deep veins first, then. The source says they're usually paired.
Yeah, typically. Think anterior tibial, posterior tibial, peroneal veins. They're paired.
Like little twin rivers.
Kind of. And they flow together, converging into the popliteal vein.
Which, interestingly, can also be paired sometimes.
It can, yeah. It's
Yeah.
not always a single vessel back there. That pairing offers some redundancy, a safety net, if you like.
But it also means if there's a clot, a thrombus, you need to know if it's one or both vessels affected.
Absolutely. It affects prognosis, treatment decisions, everything.
Okay, so the popliteal vein runs up through the adductor canal.
Correct. And then it becomes the femoral vein.
Ah, right. And that used to be called the superficial femoral vein, which was confusing.
Very confusing. Because it's not superficial at all, it's deep within the thigh, so just femoral vein now.
Much clearer. Okay, so the femoral vein keeps going up,
And it merges with the deep femoral vein.
forming the common femoral vein.
Exactly. Then, once it passes the inguinal ligament, heading up towards the abdomen,
It changed its name again.
yep, becomes the external iliac vein.
It's like learning a new language with all these names.
Yeah. It is a bit, but they're important landmarks. So the external iliac meets the internal iliac.
To form the common iliac vein.
Right. And here's a little anatomical point of interest. The left common iliac vein actually passes under the right common iliac artery.
Oh, so it's kind of sandwiched in there.
It is, yeah. A bit of a tight spot, anatomically speaking, can be relevant clinically.
I bet. And finally, the two common iliac veins, left and right.
They join together to form the big one, the inferior vena cava.
The main highway back to the heart.
Pretty much.
Okay, that's the deep system covered. What about the superficial veins, the ones closer to the skin?
Right, these are above the muscle fascia, more like surface roads, as you said. They're actually above the saphenous fascia, to be precise.
And the main one is?
The great saphenous vein, it starts down near the ankle on the inner side.
Medially, yeah.
Medially. And it runs all the way up the leg to the groin to the saphenofemoral junction.
Where it connects to the...
Common femoral vein, the deep system.
Got it. And the source mentioned tributaries, accessory veins.
Yeah, sometimes you get these variable anteromedial or anterolateral accessory saphenous veins joining near the top. Figure 20.1 in the text shows the main course nicely.
Okay. And there's another major superficial vein too, right?
Yes, the small saphenous vein. This one starts on the outside of the ankle, the lateral side.
And runs up the back of the calf.
Correct. Above the muscle compartment, covered by that saphenous fascia layer, it drains into the popliteal vein back in the deep system at the saphenopopliteal junction.
And figure 20.2 illustrates that. It also mentions it runs near the sural nerve.
It does. That's clinically important. If you're doing any procedures back there, you need to be mindful of the nerve.
Makes sense. Are there connections between these two main superficial veins?
There are. You've got the inner saphenous vein, sometimes called the vein of Giacometti, linking the great and small saphenous.
A connecting route.
Yeah. And there's also the posterior accessory great saphenous vein, which drains the inner calf, the medial part.
So a network.
It is. And these connections can become quite important if there's a blockage somewhere, offering alternative routes.
But the connections don't stop there. What about perforating veins?
Ah, yes, the perforators. Think of them as short connecting bridges.
Linking superficial to deep.
Exactly. And crucially, the normal flow is inwards, from superficial to deep.
Okay. And where are most of them found?
Mostly below the knee, typically along the inner side of the leg, the medial aspect, in a fairly narrow band.
Knowing where they are seems vital.
It is, because they're common spots for valve failure, leading to superficial venous insufficiency. Our source names some key ones: Cockett, Boyd, Dodd, Hunterian.
Like landmarks again. And figure 20.3 shows where they are.
Yep, it maps them out. Helps you visualize where problems might arise.
And they're also communicating veins.
Right. These are a bit more variable, a network just under the skin, above the muscle fascia, linking the named superficial veins together.
So it's all very interconnected. Deep, superficial, perforators, communicators.
Highly interconnected. Which brings us to the lymphatics in the lower limb.
The fluid management system.
Basically, yeah. Dealing with that extra interstitial fluid. Similar to the veins, you have two sets.
Deep and superficial.
Deep and superficial, mirroring the veins. But, interestingly, there are way more superficial lymphatic vessels.
Okay. And where do they drain?
Into lymph nodes, the filters. In the lower limb, the main clusters are in the popliteal region, maybe 5 to 7 nodes back there.
Behind the knee.
Right. And then the inguinal region, in the groin, in the femoral triangle, you can have 10 to 20 nodes there. Figure 20.5 shows this distribution.
Okay, that's a solid overview of the lower extremity plumbing, so to speak. How do doctors actually evaluate all this when someone presents with a problem?
Well, it has to be systematic. Always.
Start with the patient's story.
Absolutely. The presenting complaint. Then a really thorough physical exam, correlating what you find with their history and, the underlying pathophysiology.
And diagnostic tests if needed.
If needed, yes. And the therapy, the treatment plan, that's driven by understanding the disease itself, its natural course, how it affects the patient's life, their risk factors, their overall function.
Right. So what kind of symptoms bring people in? What are they typically complaining about?
It varies a lot. Pain is common, obviously. Weakness sometimes.
Neurosensory things too, like warmth or coolness?
Yeah. Or numbness, hypersensitivity. Then there are visible things. Skin discoloration, swelling, maybe tissue breakdown, ulcers.
Or varicose veins becoming prominent.
Exactly.
So when taking the history, what details are crucial?
Location is key. One leg or both. Proximal or distal? Onset, sudden, or gradual? How long has it been going on?
The character of the symptom. Like, is it constant? Does it come and go?
Right. Frequency, patterns throughout the day. Is it getting better, worse, staying the same? And importantly, what makes it better or worse?
Like position, activity, temperature.
All of those. Menses in women, vibration, pressure. You need to ask about aggravating and alleviating factors.
And then the physical exam builds on that history.
It does. Starts with just looking, observation, inspection.
Time changes.
Yep. Atrophy, any cyanosis or mottling, paleness, redness, that lipodermatosclerosis we'll talk about later, ulcers, of course.
And swelling edema.
Crucial. Note where it is and try to quantify it. Measuring limb circumference at specific points is really useful for comparison, tracking changes.
Then palpation. Feeling the limb.
Exactly. Checking skin temperature differences between limbs, assessing sensation, and feeling for all the accessible pulses.
Which you can't feel a pulse.
Then you grab a Doppler.
Yeah.
Essential to check for flow, especially if there's significant swelling. You need to know if the arterial supply is okay.
It sounds like quantifying the severity is a big deal in venous disease. The source mentioned several classification models.
Yes, quite a few. They give a standardized way to assess things, which is good for practice and research.
Like CEA.
CEP is a big one. Clinical, etiologic, anatomic, pathophysiologic. Very comprehensive. But there's also the Venous Clinical Severity Score, VCSS, Venous Segmental Disease Score, Venous Disability Score.
Tables 20.1 through 20.5 cover these.
They do. They lay them out. These are being used more and more in clinics, in registries. It helps everyone speak the same language about how severe the problem is.
Standardizes the assessment.
Right. And tracks outcomes better.
And for post-thrombotic syndrome specifically, is there a go-to score?
The Villalta score seems to be preferred for characterizing that condition, often used alongside quality of life questionnaires like those in tables 20.6 and 20.7 to get the full picture.
Okay, that makes sense. So we have the anatomy, the evaluation approach. Let's get into specific conditions. Venous obstruction.
Right. So a blockage in a vein, it could be completely silent, asymptomatic, like maybe an isolated clot in a tibial vein.
Or it could be really obvious.
Oh, yeah. Painful, swollen limb. Often happens when a clot extends further up, more proximally.
And you mentioned it can get serious if untreated. Phlegmasia?
Phlegmasia cerulea dolens, yes, that's severe. Can even rarely lead to limb loss. So prompt recognition is vital.
And obstructions aren't always just clots, right?
Yep.
Compression, chronic issues.
Correct. External compression can cause symptoms. Chronic old thrombosis can leave scarring and obstruction. Or the valves can get damaged after a clot, leading to reflux and symptoms that way. May-Thurner is a key example of compression.
We'll circle back to May-Thurner. Let's talk DVT, deep venous thrombosis. Very common. What's the classic presentation?
Well, classic might be strong, as it varies, but often it's swelling in one leg. Discomfort, maybe fullness, pressure, or an ache.
And the onset.
Usually acute, fairly sudden. Patients often say it's worse when they walk or stand for a while, better when they elevate the leg.
But not everyone has symptoms.
No. Especially hospitalized patients, they can have a DVT without any symptoms. And even outpatients with suggestive symptoms, maybe only half actually have a DVT confirmed.
Which underlines the importance of that history again. Looking for risk factors.
Absolutely crucial. Advanced age, being immobile for long periods post-surgery, long flights.
Pregnancy, trauma, cancer.
All major risk factors. Previous DVT, family history, known clotting disorders. Even post-COVID is mentioned as a potential factor now.
And knowing these helps with diagnosis and treatment duration, like lifelong anticoagulation.
Exactly. It heavily influences those decisions.
And DVT isn't the only thing causing leg swelling, right? The differential diagnosis.
Right. You have to think broader. Systemic causes often give you bilateral swelling, heart failure, cirrhosis, kidney problems, basically fluid overload.
And unilateral swelling could be other local things,
Okay.
yeah.
Cellulitis, a muscle tear or strain, Baker's cyst behind the knee, a hematoma, even dermatitis.
So even with a good history and exam,
You usually need imaging. Ultrasound is key to confirm or rule out DVT definitively.
the source mentions risk stratification models, like Wells criteria.
Yes, very helpful because symptoms can be so nonspecific. Wells combines clinical factors, subjective and objective, to give a low, moderate, or high probability of DVT. Table 20.8 outlines it.
And Caprini for surgical patients.
Right, Caprini is specifically validated for assessing thromboembolism risk after surgery. Table 20.9. These scores are widely used, often guiding whether you do a D-dimer test or go straight to ultrasound.
But they have limitations. Wells has subjective parts. D-dimer accuracy varies.
True, they're tools, not perfect oracles. Clinical judgment is still essential.
And knowing why the DVT happened is important too. Provoked versus unprovoked.
Vital. A provoked DVT linked to a clear temporary risk factor like surgery might need shorter treatment. An unprovoked one raises concerns about underlying issues, maybe needing longer, even lifelong anticoagulation per guidelines like those from the ACCP.
We focused on legs, but DVT happens in arms too.
It does. Upper extremity DVT usually involves the subclavian or axillary veins.
Presentation.
Often acute swelling of the whole arm can be linked to thoracic outlet issues, sometimes from repetitive activity or increasingly from central venous catheters.
Okay, back to the leg DVT. What specific things might you find on physical exam?
Unilateral swelling is the big one. If it's iliofemoral, the whole leg might be swollen. Femoropopliteal, maybe more calf and lower leg.
Left leg more common.
Interestingly, yes. Measuring circumference helps the difference over 3 centimeters compared to the other leg makes DVT more likely. If the legs are pretty much the same size, DVT is less likely.
What about joint pain or localized redness like cellulitis?
Rarely the main features of DVT itself.
And those old signs like Holman's sign, pressing the calf.
Forget him. The source is clear. Holman's, Bancroft, Lowenberg signs are unreliable. Don't base your diagnosis on them.
Okay, let's talk about the severe end of the spectrum phlegmasia again.
Right. Phlegmasia alba dolens, the milk leg. Pale, white, swollen leg, often linked to pregnancy or postpartum iliofemoral DVT.
And Cerulea dolens.
That's the really dangerous one. Phlegmasia Cerulea dolens. Massive swelling. The leg turns bluish, cyanotic. It means extensive blockage with poor collateral flow.
Risk of compartment syndrome.
Yes. And venous gangrene, potentially limb loss. It's an emergency. Needs rapid diagnosis and intervention. Getting a bedside Doppler to check arterial flow is critical because pulses might be impossible to feel.
Scary stuff. Shifting gears, slightly superficial thrombophlebitis. How's that different from DVT?
It's inflammation of a superficial vein. The key difference is it usually doesn't affect the deep system hemodynamics directly.
Usually.
Well, if it involves the great saphenous vein, there's roughly a 10% risk it can climb up and extend into the common femoral vein, becoming a DVT.
Ah, okay. Risk factors similar to DVT.
Pretty similar. Age, obesity, prior DVT or phlebitis, recent IV lines or cannulation, especially in the arm, where it can sometimes present just as a fever.
And on exam, what does it look and feel like?
Pain, tenderness, warmth right over the affected vein. You can often feel a firm cord. Might be redness, maybe streaking up the limb, which can get confused with cellulitis.
Treatment usually conservative. Eat anti-inflammatories.
Often, yes. But if it's extensive, involving a named vein, and not improving, anticoagulation might be considered.
Okay. What about the long-term fight out from a DVT Post-thrombotic syndrome.
Also called post-phlebitic syndrome. It's basically chronic venous insufficiency that develops after a DVT damages the vein valves.
So the valves become leaky, incompetent.
Exactly. After the clot resolves, or even partially resolves, the valves might be stuck open or scarred, allowing backward flow, reflux. Sometimes residual clot obstruction also plays a role.
And this combination causes problems.
Yes. Obstruction plus reflux leads to worsening symptoms with activity, that venous claudication again, increased pressure when walking, ambulatory venous hypertension, swelling, and eventually, potentially, venous stasis ulcers.
What are the early signs versus later signs?
Early on, maybe just mild ankle swelling towards the end of the day, some leg discomfort, better with rest, elevation, compression stockings help a lot.
And later?
More persistent swelling, maybe brawny, edema, tougher, less pitting. Skin changes, eczema, that brownish lipodermatosclerosis in the gaiter area.
Gaiter area being?
Lower leg, above the ankle, like where old-fashioned gaiters would sit, due to hemosiderin staining. And ultimately, ulcers can form typically around the inner ankle, the medial malleolus.
And the physical exam findings reflect this progression.
They do. Swelling again, usually unilateral if it's venous. Bilateral points more to systemic issues like heart failure. Pitting edema early on, maybe less pitting later if fibrosis sets in. You might see secondary varicose veins. And you need to document any ulcer's size, depth, location. Medial malleolus is classic for deep venous insufficiency ulcers.
And it's crucial to know if an ulcer is venous, arterial, or something else.
Absolutely vital. Table 20.0 compares them. Arterial ischemic ulcers are often painful. Distal on the footos look punched out. Core blood supply signs. Neurotrophic ulcers, often diabetic, are usually painless on pressure points. Venous ulcers fit the description we just gave, gaiter area, often medial, larger, shallower, moist base surrounding skin changes.
And any chronic ulcer needs a biopsy.
Always consider it, especially if it's long-standing or looks unusual, to rule out malignancy.
Okay. You mentioned May-Thurner syndrome earlier as a cause of obstruction. Can we revisit that?
Sure. May-Thurner is specific anatomical compression. Left common iliac vein getting squeezed by the right common iliac artery crossing over it. Sometimes there's a band or web there too.
Leading to symptoms in the left leg only.
Typically, yes. Unilateral left leg swelling, often worse with exercise. That venous claudication, again, leg pain or bursting feeling with activity relieved by rest.
Who tends to get this?
More common in younger women, often presenting after puberty, maybe with a provoked or unprovoked left leg DVT.
And if untreated?
Can lead to chronic swelling, claudication, varicose veins, even ulcers in that left leg. But importantly, many people have the anatomical compression and never develop symptoms. It doesn't always cause problems.
Interesting. Let's switch to superficial venous insufficiency, varicose veins. What's the root cause here?
Usually incompetent valves again, but this time primarily at the main junctions, saphenofemoral in the groin, saphenopopliteal behind the knee, or along the great or small saphenous veins themselves.
So reflux in the superficial system.
Exactly, leading to visible signs, telangiectasias, those little spider veins.
Reticular veins.
Slightly larger, bluish subdermal ones, and then the big, ropey varicose veins you can often trace back to the main saphenous trunks.
Hereditary component. More common in women, worsened by pregnancy.
Yes, yes, and yes. All true. Strong genetic link, definitely more frequent in women, and multiple pregnancies often exacerbate it.
What do the symptoms feel like? Is it severe pain?
Usually not severe pain, more like aching, burning, throbbing, often localized right over the varicosities. Calf swelling can happen. Foot swelling is less common.
And the pattern is typical. Worse as the day goes on.
Very typical. Better with elevation, often gone in the morning, worse with standing or sitting for long periods. Compression stockings usually help manage symptoms effectively.
What's key during the physical exam for this?
Examine the patient standing up that makes the veins pop out. Note where all the varicosities are. Look for ankle flare, that corona phlebectatica pattern.
Differentiate the types of veins. Telangiectasias, reticular, varicose.
Yes. Telangiectasias are tiny, intradermal, 1 millimeter. Reticular are 1-3 millimeter, subdermal, non-palpable blue ones. Varicose are the larger palpable ones.
Location gives clues to the source.
Often. Medial leg varicoses frequently link back to the great saphenous or perforators in that area. Posterior calf often relates to the small saphenous.
And reflux isn't just at the top junctions, can be perforators too.
Absolutely. You need to consider incompetence in perforators like Dodd, Boyd, Cockett, Hunterian. Figure 20.3 shows where they are. Hunterian incompetence might give you mid-thigh varicosities, Dodd lower thigh, Boyd near the knee, Cockett-Sherman near the ankle.
So duplex ultrasound is needed to pinpoint these.
pretty much essential to map out the reflux accurately,
Yeah.
specifically the perforators. And remember, in obese patients, you might feel the varicosities even if you can't see them well.
Good point. And check the arms, too.
Yeah, just to see if they generally have prominent veins. Might normalize prominent leg veins. The Aberdeen Varicose Vein Questionnaire, Table 20.7, is a good tool for patient-reported outcomes here.
What about Trendelenburg and Perthes tests?
Historically used, but our source notes they're infrequent now. Duplex ultrasound has largely replaced them.
Okay. Klippel-Trenaunay syndrome. That's a bit different, isn't it? Congenital.
Yes, congenital. It's a classic triad. Varicose veins, a port wine stain birthmark, and overgrowth hypertrophy of bone and soft tissue can cause a limb length discrepancy.
Sometimes called Parks-Weber if AV malformations are present.
Right, or Klippel-Trenaunay-Weber usually affects one limb, often a leg.
What's most common in the triad?
The port wine stain is seen most often, then the varicosities, then the hypertrophy. The varicosities and stain are usually there from birth or early on, though varicosities might become more apparent around puberty.
And the veins involved can cause pain or ulcers.
They can.
What to look for on exam?
Look for the triad elements. The stain, usually on the affected limb. The varicosities classically starting lower down and extending up, often smearing the main saphenous veins. And check for limb size differences or signs of AV malformations.
Crucial point about the deep veins here.
Yes, very important. Before treating the superficial varicosities, you must confirm the deep system is patent because some KTS patients have underdeveloped or absent deep veins.
Got it. Venous aneurysms, you said uncommon?
Relatively uncommon, yes. An isolated, localized bulge or dilatation in a vein can be superficial or deep, upper or lower extremity, not linked to AV malformations or pseudoaneurysms.
Causes, associations.
Affects men and women equally, no real age link, may be associated with saphenous reflux, might be underdiagnosed, mistaken for soft tissue lumps. Etiology could be congenital, trauma-related, or linked to varicose veins. Some association reported with Klippel-Trenaunay, too.
How do they present?
Superficial ones might be asymptomatic or just cause swelling, maybe some discomfort. Deep vein aneurysms often present after a clot forms in them, like a DVT, popliteal is common, or sometimes they're found as a source of pulmonary embolism.
Exam findings.
Standing helps see superficial ones better. Need to be careful examining groin lumps. A saphenous aneurysm can mimic a hernia. Pain might mean it's thrombosed. Deep ones usually diagnosed on imaging like duplex, often presenting like a DVT.
Okay, last major topic, lymphedema. What's the basic issue?
The lymph system is blocked or impaired, can't drain fluid properly. So protein-rich fluid builds up in the interstitial tissues.
Classified in different ways, primary versus secondary.
Exactly. Primary is intrinsic, often genetic, can be congenital at birth, like Milroy disease, precox, onset age 135, most common type, often puberty, more in women, or tarda, onset 35, also more in women.
And secondary is acquired.
Yes, much more common overall. Caused by damaged lymphatics, infection is a big one, globally filariasis. In developed countries, probably lymph node removal or radiation for cancer is the most frequent cause. Trauma, the cancer itself, other infections too.
Sudden onset later in life needs specific thought.
Yeah, definitely ask about travel history. Consider infection or malignancy.
Where does it typically occur? Exam findings.
Lower extremities most often. Upper extremity often follows breast cancer treatment, axillary dissection, usually unilateral. Key feature. Elevation doesn't really resolve the swelling, unlike typical venous edema.
Starts distally, involves the toes.
Often starts distally, yeah. And classically includes the toes and foot, which helps differentiate it. Begins as mild pitting edema, slowly worsens, usually painless, can spread proximally, even to the trunk genitalia.
Stammer sign.
That's a key sign. Inability to pinch the skin on the top of the foot between the first and second toes indicates lymphedema. Toes can get squared off, boxcar appearance.
Later stages.
Skin thickens, fibrosis occurs, can get ulcerations, fissures, lymph leakage, lymphorrhea. Also prone to infections like lymphangitis, red streaks.
Staging exists.
Yeah.
Based on pitting, fibrosis, reversibility.
Yes, Table 20.11 classifies the causes. The Warren Review is cited as a good resource for more depth.
Okay, we spent a lot of time on the legs. Briefly, the upper extremity anatomy, similar principles.
Very similar. Deep veins. Paired radial and ulnar in the forearm.
Form the brachial veins at the elbow.
Right. Brachial becomes axillary, then subclavian as you go up towards the chest.
Superficial veins in the arm.
Main ones are cephalic and basilic. Cephalic runs laterally up to the shoulder, joins the subclavian. Basilic runs medially, dives deeper in the upper arm to join the brachial or axillary. Figure 20.4 shows these.
Lymphatics follow the vessels too. Nodes in the axilla and supraclavicular area.
Correct. Follow the vessels, nodes concentrated proximally in the axilla and above the collarbone. Figure 20.6.
And clinical evaluation principles are the same for the arm.
Exactly the same systematic approach. History, physical exam, diagnostics if needed, tailored therapy.
Well, that was definitely a deep dive. We've covered a huge amount on evaluating the venous and lymphatic systems in arms and legs, really leaning on that textbook chapter.
It really highlights how complex yet vital these systems are, and how crucial that thorough clinical evaluation is, blending the patient's story with physical findings.
Yeah, understanding the underlying issue is key. We saw such a range of conditions, didn't we? From simple varicose veins to life-threatening phlegmasia or chronic lymphedema.
Underscores the need for accurate diagnosis.
Absolutely. So maybe a final thought for you, the listener, to ponder. Considering this complexity we've discussed, all these potential problems, what do you think the next big leaps will be? Where will future advances in diagnostics or treatments make the biggest difference for venous and lymphatic health?
Something to think about. We definitely encourage you to explore the chapter further or look into related resources if this sparked your interest.
Thanks for joining us on this deep dive.